All right, good morning, everybody. Welcome. Thank you for coming. My name is Erin Jones, and I work with the March of Dimes, and I serve as legislative counsel. And I'm excited this morning to talk about vaccines because it's something that I've been working on with the March of Dimes for many years. We also want to thank some of our congressional sponsors this morning, which is Representative Larry Bucshon of Indiana and Representative Kim Schreier of Washington. Both members have been very good to us and have been great leaders and advocates on behalf of moms, babies, and families. So we thank them both for being here. Our mission at the March of Dimes is to lead the fight of health for all moms and babies. March of Dimes believes in a world where every mom and baby is healthy regardless of wealth, race, gender, and geography. March of Dimes is fighting to end maternal mortality as well as end preventable preterm birth and infant death and close the health equity gap. And so building on our 85 years of success of improving maternal health across the country, we are support of all moms and babies, and we want to make sure all moms and babies are up to date on all their CDC recommended immunizations. So without further ado, I would like to give this opportunity for all of you to meet our sponsor for today, Representative Larry Bucshon.
Well, thank you. I hope some more people come in the door. This is a really, really important. It's great to be here. I'm a cardiovascular and thoracic surgeon by training. I've been in Congress now for, this is my 13th year, 7 terms. And I'll just be brief, but during the COVID pandemic, myself along with the other doctors in Congress on both sides of the political aisle did our best to educate the American public on the benefit of COVID-19 vaccination. And we had challenges on both sides of the aisle, our constituents on both sides of the aisle for different reasons and different challenges, but I just want to let you know up front that the doctors in the Congress were big promoters of getting people vaccinated during the COVID-19. And the other thing we did is we tried to, and I think we're successful for the most part, debunk urban myths that were all over the internet. And that was a big challenge. You know, I couldn't agree more. What you just talked about what March of Dimes is focused on, ditto. I couldn't agree more. You know, when I was a medical student at University of Illinois, I had one of my first patients had pertussis. I mean, was hospitalized and was sitting up doing the whooping cough type thing, and that was one of my first exposures to what happens when people are not properly vaccinated. In the city of Chicago, of course, you see a lot of things. But this was something that if any of you have ever seen that, it sticks with you and has stuck with me for over 30 years. You know, I really consider vaccination one of the biggest medical achievements in medical history. When you look back at the history of where we were with childhood illnesses and other illnesses like polio that affected children and adults, it's very clear that the advent of vaccination is one of the biggest accomplishments in history. And I do think during COVID-19, with the Operation Warp Speed under both administrations, the previous administration, the current administration, that 50 years from now, people are going to be applauding it as one of the biggest accomplishments in vaccination history because of the quick advent of a vaccination specifically to end the pandemic. You know, we still have a building challenge against vaccination, and it's not just political. I would say it's populist. And you see that both with celebrities and politicians. And that's unfortunate. And we need to try to reverse that, and I know you're doing your best. So I really think it's incumbent upon leaders, both in organizations like the March of Dimes, as well as in Congress, and other leaders around the country to aggressively educate the American people again for the umpteenth time about the benefits and try to what we try to do as the Doctors Caucus is we try to use medical facts, medical data, and again, not urban legends or not what people feel. For example, I don't know if you know this, but LeBron James's son, Bronny James, just unfortunately had a cardiac arrest and which happens in young people just randomly. Who knows why? They'll never know why, probably, and they may find out. But it's all over the internet that it's because of he was vaccinated for COVID-19, right? It's all over the internet, including Elon Musk mentioned it, believe it or not, who has a huge platform. And unfortunately, people like us, scientists, people that run organizations like March of Dimes, members of Congress, we get drowned out by the celebrity aspect of it. So that's our challenge. And so that's why it's so important that the March of Dimes is what you're doing to raise awareness and help accomplish the goal of making sure not only children receive routine vaccination, but also adults. And that is important. My daughter well, my wife is an anesthesiologist, and she recently had a patient who was not properly vaccinated, and she anesthetized women at women health care centers, and this was a lady in her 30s who had a precancerous cervical lesion and had the opportunity to be vaccinated against that and did not. And so it's a problem. So again, thank you for being here. Kim's not here. Dr. Schreier is not here. I'm not sure she had another commitment. But the final thing I'll say is we work bipartisan. The doctors do. Don't believe what you see on TV, okay? Believe some of it, but not most of it. Now, I can speak for the physicians in Congress. We work bipartisan because our goals are the same, and the goals are very similar to what was mentioned at the March of Dimes. But for me personally, it's all about patients. It's all about people. And whatever policy goals, we may have some disagreements about how to get there, but the end result is the same. We want everyone to have access to quality, affordable health care, regardless of your zip code. And we know there are disparities out there, and we're fighting to improve the situation. So thank you very much. I hope you have an interesting and informative discussion. And again, I appreciate you. Thank you very much.
All right. Well, we're kind of a small group, so I hope this is interactive. So we've put together a panel for you that's going to talk a little bit about 3 key things that we want to make sure that you walk away from here knowing, and if you don't, ask the question because we want to make sure you know. So one is vaccine knowledge. We want you to be and understand how to educate parents and individuals on routine vaccines and what the recommendations are, as well as vaccine trust, enlisting and how we enlist and get the trusted voices from the communities to be a part of this conversation. And then finally, vaccine equity. We can't do this if we don't look at the equity complexity of vaccines and making sure we're getting them out to all families. So I'm gonna go on here and introduce each one of our panelists, because we've put together a diverse group of people who are going to talk a little bit from their perspective. But again, since we're a small group, please feel free to ask questions at the end so that we can have interaction. And make sure that you don't walk out of here going, I wonder what they meant by that. Or I never got a chance to ask. So please feel free to do that. So first, I would like to introduce, let me make sure I got all my notes right here, Dr. Georgina Peacock. She is the director of the Immunization Services Division in the National Center for Immunization and Respiratory Diseases at the CDC. In this role, Dr. Peacock oversees support of immunization programs, provider and public education, and evaluation and research. Dr. Peacock formerly served as the director for the Division of Human Development and Disability in the National Center on Birth Defects and Developmental Disabilities, also known as NCBDDD. We all love our acronyms in MCH, right? We all love our acronyms around here. During her 15 years with CDC, Dr. Peacock has been dedicated to developing and implementing public health programs that support children and adults in underserved populations to lead healthy lives and be productive members of their community. Dr. Peacock served as an integral part of the COVID-19 response on the vaccine task force. She also served as the Chief Medical Officer for CDC at the Georgia Department of Public Health, supporting the state's vaccine efforts. In addition to her role at CDC, Dr. Peacock sees patients at the Good Samaritan Health Center and the Children's Healthcare of Atlanta's Developmental Neurology Program, both developmental clinics located in Greater Atlanta area. Dr. Peacock received her doctorate of medicine and master's in public health from the University of Kansas. She's completed her developmental behavioral pediatric fellowship at the Developmental Disability Center at the University of Kansas and Medical Center. There's a quiz if everybody remembers all that. Our next guest is Dr. Jonathan Davis. He is currently conducting cutting-edge research on neonatal abstinence syndrome, which is babies born that have drug addiction, and developing new therapeutics to prevent neonatal lung injury. His research has focused on breathing problems in newborn infants, cause of newborn brain injury, and neonatal drug improvements and developments. He is the Vice Chair of Pediatrics and Chief of Division of Newborn Medicine at Tufts Medical Center in Boston. He also serves as a professor at Tufts University School of Medicine. He has also served on many federal panels and is currently chair of the Child Health Oversight Committee at NIH and the Neonatal Advisory Committee in the Office of Pediatric Therapeutics at FDA. Dr. Davis is a board certified and a neonatal perinatal medicine in pediatrics. Welcome. And then we have Dr. Michelle Fiscus, and she is a board-certified pediatrician and board and public health advocate who practiced general pediatrics in Franklin, Tennessee for 17 years before transitioning her career to public health in 2016. She served as a medical director of the Tennessee Department of Health Vaccine Preventable Diseases and Immunization Program and led the state's COVID-19 vaccine efforts until July of 2021. She now serves as the inaugural Chief Medical Officer of the Association of Immunization Managers, the professional organization of the 64 CDC-funded immunization programs across the United States, territories, and major cities. Dr. Fiscus also serves as a senior health policy consultant for the National Academy for State Health Policy and serves on the board of directors of the American Academy of Pediatrics, representing Tennessee, Kentucky, Virginia, and the Carolinas. Welcome, all of you. We do have one more guest who I will invite as soon as she comes in. All right, without further ado, I'm going to allow Dr. Peacock to give her presentation.
Hi, it's great to be here, and as you just heard, I'm Georgina Peacock. I'm the Director of the Immunization Services Division at CDC, and really pleased to be here today to talk to you briefly about a few things: our domestic immunization program, the effect of the pandemic on routine vaccinations, efforts to increase vaccine coverage, and then I'll end with a little bit of information about our fall-winter respiratory planning. So to start with, I'd like to just point out that these are really the ways we try to achieve increasing vaccine coverage. So you'll see that we have different goals: increasing vaccine access, promoting vaccine confidence and demand, enhancing data and research and evaluation. So we need to be able to look at the data related to vaccine coverage in order to make good decisions about the things that we do, strengthen program support for partners, improve health equity, and enhance vaccination response readiness, which has become very clear in the pandemic, but also with things like outbreaks of measles or the polio case that we saw recently. So our goal is to create a comprehensive domestic immunization program, and you'll see here in this circle diagram that we have different pieces that contribute or may contribute to creating this comprehensive immunization program. So first we have our what we call our Section 317 program. This is the discretionary portion of the domestic program that we run. Then, of course, there's the very well-known Vaccines for Children program, which is the mandatory part of our program that serves 50% of children in the United States. So about 50% of children in the United States receive vaccines through the Vaccines for Children program. And then finally, the proposed Vaccines for Adults program, which would complete this circle where we would have coverage for uninsured adults for routine vaccination. So through this is how we envision both providing and promoting vaccination across the lifespan. So first, to start with our Section 317 program, which is called Section 317 because it's authorized under Section 317 of the Public Health Services Act. It has a 60-year history, and really the purpose of this funding is to support the essential public health workforce and systems at the national, state, and local levels. So this is what we have as sort of our backbone for that infrastructure that supports the domestic program. And I'll go into some details about some of the activities that this support, but I think that the majority of this funding, as we heard in one of the introductions, and Shelley will talk about in a little bit, is the funding of our 64 grantees. So those are the 64 immunization programs that administer the Vaccines for Children program across the country, as well as support all of those other immunization efforts that I'm going to talk about in a minute. So here's some examples of other things that are covered in the Section 317 program. So we use this funding to identify gaps in routine immunization. So part of that is by supporting different data sources that we use to understand vaccine coverage, vaccine intent, things like vaccination intent, things like that. So the National Immunization Survey, the Behavioral Risk Factor Surveillance System, that looks more at adult immunization, and the Immunization Information Systems, which are those systems in all of the immunization programs across the country that help us understand vaccine coverage from an administration perspective. Also conducting vaccine research and evaluation. Some of the examples of this are the production of the State of the Vaccine Confidence Insights reports. We also use vaccine economic modeling and cost effectiveness studies. A lot of that informs discussions in the ACIP, the Advisory Committee on Immunization Practices, as they're looking to make recommendations for different routine immunizations. This funding also supports promoting and monitoring vaccine safety. So both on the education side, so provider guidance for the storage, handling, and use of vaccines, as well as things like vaccine safety monitoring through the VAERS program, or the Vaccine Adverse Event Reporting System. And then finally, I mentioned in the beginning, responding to public health emergencies. So that's both, creating emergency communication tools and support, and also supporting vaccine distribution if there is an outbreak somewhere. And then, of course, the biggest example, of where we provided also additional support was in the pandemic, and that was where the expertise of those working in the Immunization Services Division who are focused on vaccine implementation provided some of that experience and expertise working with others to deliver those vaccines. So this is the Section 317 budget appropriations, and just real quickly to see where the funding has been over the past couple years, and then where the proposed 2024 President's budget sits. So now I'll move into some of the other pieces of the domestic program. So as I mentioned, the Vaccines for Children program is the major program that we administer through the Immunization Services Division. And through its 30 years has prevented 472 million illnesses, avoided over 1 million deaths and saved nearly 2.2 trillion in total societal costs. And as a reminder, this program provides vaccinations for around 50% of children in the United States that wouldn't have access to vaccines through a private source. And then finally, I talked about the proposed Vaccines for Adults program that would reduce the spread of vaccine-preventable disease and also provide greater health equity for those 24 to 30 million uninsured adults in the United States. And so this proposal is built on the framework of the Vaccines for Children, acknowledging that there are differences between the way children receive health care and the way adults receive health care. So this would include vaccine purchase, and then also includes pieces to support that program. So program operations at CDC that is both supporting systems as well as scientific and policy support, program monitoring and vaccine safety. And then pieces for provider fees and provider fee management. And finally, to underscore, and you've already heard this in some of the comments today, that need for vaccine confidence and equity activities to make sure that those vaccines reach the people we are intending them to reach. And none of this could be done without partners. And there's a few pictures of partners, or a few names of partners on here, but what I will say is that we've had hundreds of partners, especially during the pandemic period, that have supported the work related to vaccine confidence, the work related to health equity, in order with all of the same goal, which is to increase vaccine coverage for routine immunizations as well as those that are used sort of in emergencies. So now I will switch gears and talk a little bit about the effects of the pandemic on routine immunizations. So this is now, feels like an old slide. This is a slide from 2020, but what you'll see is on March 13th, when the United States declared a national emergency related to the pandemic, you saw a huge drop-off in the provider orders that came into the Vaccines for Children program. There are reasons for that. Well-child visits weren't happening, and so children weren't getting vaccinated. And one way to look at that is to see how these provider orders dropped off significantly and very quickly. So I'm going to talk a bit about what those effects were, and then at the end we'll show you where we are now. So when we look at the effects of the pandemic on routine childhood vaccination, there are a few sort of data pieces that I can share that really demonstrate some of those effects. So in 2-year-olds living in poverty or in rural areas, we've seen about a 4 to 5% decline in that combined 7 vaccine series coverage among 2-year-olds. That information comes from the National Interview Survey. Another way we look at this is by looking at kindergartners. So what do kindergartners have as far as their vaccinations as they are about to enter school? And what we have found over the last 2 years, that we saw a decline from about 95% full coverage to 93%. So what does that mean? Because that doesn't sound like a lot. So this was, and when we look at coverage, we're looking at MMR, DTaP, polio, and varicella vaccines. But what that equates to is that there is potentially about 275,000 kindergartners who did not have those required vaccines or those recommended vaccines as they entered kindergarten, so may not have been, obviously those challenges around health, not only for those children, but those around them could be consequential. So there's an importance in continuing to need to monitor this. What I'll say is that we do have very high vaccine coverage rates in the U.S. among children, but it's important for us to be monitoring because we certainly have seen the effects of the pandemic on this and, need to make sure that we're starting to rise back to where those coverage levels were and even try to exceed those. You know, when we look at adult vaccination, it's a similar story. We actually saw a very significant decrease in vaccines for children orders for HPV, meningococcal, and Tdap vaccines in adolescents. When we translate that to coverage, so when we look at the National Interview Survey data, we saw that with men ACWY and also Tdap, their coverage fell about 4 to 5% in teens through the pandemic. We saw a more dramatic drop in HPV coverage, and that's where we're really actually not seeing the rebound that we're seeing in some of these other areas. So what are some of the things that are being done to increase vaccine coverage related to initiatives and campaigns? So one of them is an initiative that we started in January of 2023, which is the Let's Rise initiative. So the Let's Rise initiative is looking at the data that we have related to vaccine coverage and working very specifically with immunization programs as well as providers to use that data to look at where we should target efforts, whether that's targeting with partnership work, whether that's targeting with health communication campaigns. And so it's a way that we can work hand in hand with our immunization programs in order to use data to kind of inform where that focus occurs. In addition, we have sort of reinvigorated or reactivated our paid digital Let's Play Catch-Up ads. This is a communication component of that Let's Rise framework, and it's being rolled out right now, so it's running between July and September as part of a back-to-school campaign. So these digital ads are nationwide, both in English and Spanish. There's also MAT releases, and there's other communications that are both CDC branded, but then also unbranded, so that our immunization programs and our partners can also use these communication assets as part of their campaign to encourage routine childhood vaccination during this back-to-school period. It is about to be, so August is National Immunization Awareness Month, and so I think you'll continue to see efforts to use social media on CDC platforms. I think other partners may amplify this, and then using, you know, the communication materials that I shared prior to really and reinforce the importance of routine childhood immunizations during this period. And of course there is, and this is actually an activity related more to adult immunization, but we have done a lot of work working on vaccine equity. This particular slide talks about our PAVE program, or Partnering for Vaccine Equity, which is a partnership where we have worked with many community-based organizations to improve the work around adult immunization related to both equity and then also increasing vaccine confidence. So I said that I would come back and show you kind of where we are, and one way we look at vaccine coverage is we can look at vaccines for children ordering. And so you'll see here, this starts with fiscal year 19 and the orders that we have had over the last few years. The orange part is the first portion of the fiscal year, and the blue part is the second portion. So that's why in FY23 you're not seeing that blue portion, because we're not to the end of the fiscal year. What you can see is what we are talking about, kind of pre-pandemic or baseline in FY19 all the way over on the left, and then definitely dips in provider orders over the next couple years. We're really encouraged to see that that vaccine ordering is returning to baseline. However, what we also know is that there are places in the country, maybe on a census level tract or on a county level, where we see vaccine coverage that can be much lower. And so this tells one story. This shows you sort of where we are nationally, but we recognize that there are areas of focus or communities of focus that need that additional work in partnership with our immunization programs, in partnership with our partners to do this work. And so now I'm going to touch very briefly on where we are with fall planning. So not only is the routine childhood immunization and the adult immunization work, but there's a focus this fall on thinking through what we can do to prepare for what we call the pan-respiratory season, so thinking about influenza, COVID-19, and also RSV. And, for the sake of time, I'm not going to go through all of these goals, but suffice it to say that we're working at different angles in order to think through how to best support this work in the fall-winter season. So with influenza, as has happened for many years, there's a very strong communication campaign talking about the importance of seasonal influenza vaccine. And on the surveillance side, good monitoring related to both, influenza prevalence, so what's happening with the disease, as well as being able to monitor vaccination through the Flu VaxView. Both of these you can find on the CDC website. The second thing that has had a lot of attention, we're seeing things in the media, is the RSV. So there are a number of things that have happened with RSV vaccination. There is an approval of 2 vaccines licensed for 60-year-olds and older that was recommended recently by CDC. Those are going to start to roll out, and so that RSV vaccine will be available for older adults. And in addition, on July 17th, so just very recently, Nursivimab, which is a monoclonal antibody, was licensed by FDA to be used as an immunizing agent, so universally in infants, to protect against RSV. And so in the upcoming weeks, there will be discussions with the Advisory Committee on Immunization Practices, or ACIP. There's a meeting on August 3rd to look at what those recommendations will be for Nursivimab, which is a very exciting place to be. I know as a pediatrician, I mean, that's what I spent all winter doing as a resident was, admitting children for RSV, infants for RSV, and having this opportunity for an immunizing agent that may prevent a lot of that is really just an amazing milestone. And then finally, what's happening with COVID. So COVID is moving into commercialization. That is going to happen sometime soon, likely sometime this fall in September. That means that COVID-19 vaccine will not all be purchased by the federal government, but there will be private and public purchase of that vaccine. And so that is coming. And then because of the commitment to a focus on health equity, there's been a bridge access program that is being put into place for those uninsured Americans that don't have access to vaccines through another means. And so this will provide no-cost vaccine for that group of individuals. And we recognize that through all this, there have been challenges to vaccine confidence. And talking about the importance of vaccinations, as we heard just before, that this is really one of the most amazing contributions, I think, to health and to public health that we have. And so thinking about the importance of immunization and promoting vaccine confidence is so important. So I will leave you with this last picture, which is the ladder of building demand or working on vaccinating with confidence. So we know that this starts with trust. Vaccines need to be accessible. People need to understand the benefits, health benefits outweighing those risks of getting vaccination. Needs to be convenient. So those are things like reducing out-of-pocket costs, social and opportunity costs. It needs to be appealing. It needs to be that norm. This is something that keeps us healthy. And then, there are some requirements that are put into place, but that really happens kind of at the end, because if we make these vaccines accessible, beneficial, convenient, and desirable, and part of the norm, hopefully we'll be there with a much more highly vaccinated public. So thanks for having me today, and I'm looking forward to the discussion.
Good morning. Thank you for being here. We really need your help, and that's part of the reason I came down from Boston today. It's interesting to be standing here on behalf of the March of Dimes because, as you all know, talking about vaccines, the March of Dimes was started by Franklin Delano Roosevelt with a mission to eliminate polio. And for many years, I stood up here and I said the March of Dimes is the only charitable organization in history to have achieved all its goals, its initial goals. And when they cured polio and eliminated it, they switched over to taking care of premature babies and working on healthy mothers and babies. As a newborn intensive care specialist, that was important to me. And actually, the March of Dimes gave me my first research grant as a young doctor and invested in my career. So I'm delighted to be here a number of years later. I'm going to keep my remarks brief just so we can get to some of the questions that you have that are really so important. These are a number of my current positions, just to be fully transparent. I do work as a senior advisor to the Office of the Assistant Secretary of Health on the opioid epidemic. It's one of my interests. On the board of directors here at Children's National Hospital in DC, and my work at the FDA to advise them on neonatal and pediatric issues. I've really enjoyed the opportunity to interact with so many of you and your representatives and senators. It's been important. I worked on helping to pass the FDA Safety and Innovation Act, which required FDA, against their interests, to hire more pediatricians and neonatologists to help take care of pregnant women and babies, and it really has made a huge impact. I worked with Congresswoman Clark and Senator McConnell to pass the Protecting Our Infant Act, which was designed to help families impacted by the opioid epidemic. It passed by unanimous vote in the House and the Senate, one of the last bills in the last several years to do that, so something I'm very proud of. President Obama sent me the legislation signed that sits on my wall now. So we can make a difference, and I think that's why we're really here. You know, children really need to be protected from vaccine-preventable diseases. That's easy. Even when I was a resident at Boston Children's Hospital in the 80s, taking care of children with a variety of different illnesses. And now, because of vaccines, many of the kids that I saw either die or develop serious complications, my residents don't even know what that bacteria or virus is. They've never seen a case before. So we've made such tremendous efforts moving forward. But because of the pandemic, many children are behind with routine immunizations. And the World Health Organization has suggested that vaccine hesitancy is one of the most important public health problems in the world, and something that we all need to be aware of. There's many cases of measles being reported throughout the United States. Even in 2023, we had an outbreak in Ohio, of which half of those children ended up being hospitalized. So it's here. We're dealing with it right now. And that's really important. It's usually brought in by global travelers. Now, it's been great for me by Zoom. I don't have to go around the world anymore to give talks and things. I can just do it from my own office and go home afterwards. But there's the global nature of our business. Many of you are engaged in that. And these are travelers bringing in diseases from other parts of the world where the immunization practices may not be as robust as ours. 1 in 1,000 cases of measles will either die or develop serious infections of the brain. And what's interesting is that natural measles infection impairs the immune system. So people will say, oh, so let the kids just get measles. We used to have chicken pox parties to get the kids exposed. Well, natural measles interferes with the patient's own immune system, making them more susceptible to other types of diseases. You don't see that with the vaccine. So it really does make a difference. And amazingly enough, there are new cases of polio. I don't know where this virus has been the last 30 years since we last saw a case, but there was a affected patient in New York, and now we can detect certain viruses in wastewater facilities because they are transmitted through the fecal route. And there is evidence of poliovirus in the water in New York City and in London. So this virus is out there just waiting to take opportunities to make an impact. The vaccines are safe. Injury is rare. There's 30,000 doses of vaccine administered every second around the world, preventing 2 to 3 million deaths per year. Billions of doses have been administered. You don't think we'd know if they weren't safe? If it had that much of an impact and caused that much harm, even if it's 1 in 1,000 or 1 in 10,000, when you're giving 30 billion doses, it's going to show up. What's really important, and if you remember anything that I'm going to tell you, this is it over the next few lines. The FDA approves each vaccine after studies involving thousands of patients and looking at safety and efficacy, and as you heard, the CDC implements these programs. Multiple surveillance systems exist, and you've helped pass and your representatives and senators have helped pass the National Vaccine Compensation Program. There's relatively few, and that's only if it doesn't even have to meet the legal definition. It's just anyone who even thinks their child has been injured by a vaccine can apply, and yet relatively few people do. Now, here's the most important point that I'm going to bring to you. So if your child or grandchild or brother or sister or anyone goes to a pediatrician or goes into the hospital to be treated for a serious illness, only 50% of the drugs that we use are approved by the FDA for use in children. Now, I work in the newborn intensive care unit, taking care of these little 400-gram, 14-ounce babies. Only 20% of the drugs we use, are approved for use in infants. That means I just don't have anything else that I can use, so I take an adult drug, I shrink the dose down, and I give it to the babies. Maybe there's some small studies in other children, but does not even come close to reaching the intense review of vaccines because they're going to be used in so many people. So most people will take their child with cancer. Are they going to just let their child die? Of course not. And the doctor says, well, here's the chemotherapy we need to use. And the mother says, of course, I don't want my child to die of cancer. Yet, the chemotherapy, none of it is approved for use in children in many cases. So this is really important. Who are we protecting with these vaccines? It's prevention. And I know we're all reactive. We respond to crises. And that's how we are programmed. And that's why the prevention is so important and why we need your help. Adults and children with cancer who are immunocompromised or can't be vaccinated, all my little premature babies. You're spending $29 billion a year on prematurity, and I'm working day and night to save these little babies, and I send them home, and they're exposed to their brothers and sisters who aren't vaccinated and who could kill them very quickly. That's the scary part for me. Underrepresented populations are at the highest risk. Now, in Massachusetts, we're always taking our bow. People call us the healthcare and biotech capital of the world, and we're all very proud of that. And I'm at Boston Children's and Harvard, and I say this is just terrific. Yet, the CDC says we have some of the best immunization rates in the entire country. So that's something we're very proud of. Yet, we did a deep dive into the Massachusetts Department of Public Health data, and we found that more than 200 kindergartens don't even report their data on immunizations to the Massachusetts Department of Health. And 150 more kindergartens don't even come close to reaching the CDC values for herd immunity. So we're at risk in Massachusetts. And there's some of us that are really working very hard to increase those immunization programs. And yet Massachusetts is one of the better ones. There's tremendous variability throughout the country, and that's something that we need your help trying to address. So now is not the time to take our foot off the gas. and to say, well, the budgets are tight, you know, where's the money going to come from? That's your problem. I get it. All I know is I pay the taxes. You get to take that money and put it to the best use. And I can tell you from a medical standpoint, as you're hearing, this is the best use of those funds. There's good news in this. The World Health Organization and the American Academy of Pediatrics recently announced that 4 million more children were vaccinated worldwide in 2022 compared to 2021. So we're making progress. We have to continue to push forward. The U.S. is the biotechnology capital of the world. We're developing new vaccines every day here. And you heard about the respiratory syncytial virus. Last year, because of the pandemic ending and people were sending their kids back to daycare, people were taking their masks off, we had the worst respiratory virus season in children in 40 years. Do you know, at one point, I sent a baby from Boston to Albany, New York, because there was not a single pediatric intensive care bed in all of New England, not one. And we were sending kids from Boston to Maine, all over the country. My compatriots and colleagues were telling me the same thing. And a lot of it was due to this RSV virus that has a huge impact on young babies. So a single dose of this immune globulin will protect babies for the entire RSV season. And what's more important is it's not only the highest risk babies like my prematures, but even normal infants. It's going to be a game changer. We're also working on rolling out a vaccine for pregnant women. So if they're pregnant, they'll be protected from RSV, but those antibodies will cross the placenta into their babies, and the babies, without getting immunized, will be protected for the first 6 months of their life. That is huge, huge game changer. And they're over 80% effective at preventing hospitalizations. Incredible. There's an urgent need to maintain and expand these vaccine programs for children, especially for the underrepresented communities that we're not having as much of an impact on that we should. And that's why we need your help. How do we build trust with those communities to get them to listen to us? And it's still the local pediatrician, the people at the family health center that all the studies suggest are the best people to be talking to their patients, because they do have that level of trust. So I'm going to stop there and look forward to speaking more about this with you, and thank you again for being here.
Good morning. As Erin so kindly introduced me, I'm Dr. Michelle Fiskus. I'm a pediatrician, and I am the Chief Medical Officer at the Association of Immunization Managers, and I'm grateful to be here to represent the 64 CDC-funded immunization program managers across the 50 states, 8 U.S. territories and affiliated states, and 6 major cities, including right here in Washington, D.C. As a pediatrician, I spent a lot of time educating parents about vaccines, and I graduated my pediatric residency in Indiana in 1997, and in 1998, this fellow, a former physician from Britain, Andrew Wakefield, published what has now been determined to be a fraudulent study trying to connect the measles, mumps, and rubella vaccine to the autism of, to the development of autism. And it's eventually been determined that Wakefield did this for his own financial gain by fabricating the results of this paper. It took the Lancet 12 years to completely retract this paper, and meanwhile, disinformation about vaccines circulated around the world and created a lot of confusion for parents who were just trying to make the right decisions for their babies. Pediatricians have been working to restore that confidence in vaccines ever since Mr. Wakefield in 1998. Prior to the pandemic, much of the mis and disinformation that was circulating on social media was coming from outside the United States, from other countries, and then from this patchwork of local kind of grassroots anti-vaccine activists around the United States. The international players were organized and well-funded, and countries like Russia used social media bots and troll farms to spread rumors and myths about vaccines, helping to persuade a small but growing number of parents to either delay or maybe just skip altogether the vaccinations for their children. And so in this country with historically high immunization rates, that didn't pose a huge problem right at first. When was the last time we saw someone die from diphtheria or use an iron lung for someone who had contracted polio? It's exactly because of the efficacy and the safety of the vaccines that we give children that we don't hear about children suffering from these diseases. But the pandemic brought with it this seismic shift in the world of vaccine mis and disinformation. And now, as stated in a report from the Public Good News in April, the call is coming from inside the House. Most of the vaccine mis and disinformation that is now being circulated originates in the United States and is being shared widely, not only by those who seek to profit from clicks and book sales, but also from individuals with very public platforms. And lately, it has also found support in our state legislatures and from those who hold and hope to hold even federal office. The irony, of course, is that the vast majority of people who spend their time advocating against vaccines for children are vaccinated themselves. And so they work to deny children of the protection that they themselves have benefited from for decades. In 2023, hundreds of anti-vaccine bills were introduced in state legislatures across the country, including bills that attempt to remove school requirements for vaccination, move authority for deciding what vaccines are required from health experts to legislators, and attempts to ban future vaccine requirements. Fortunately, very few of these bills were enacted. But it shouldn't be a surprise that given the environment in which many immunization programs find themselves, that messaging around vaccines has become stifled. This while we see declines in kindergarten student vaccination rates and some states with nearly 50% of their adolescents still unprotected against HPV-related cancers that can almost be prevented 100% of the time by a safe and simple vaccine. When we are not encouraging parents to vaccinate their children, when we are afraid to speak out against mis and disinformation that is spread by people who have platforms, the disinformation is given space to breathe and grow and spread, and predictably, so do those outbreaks. Since bacteria and viruses that cause disease don't recognize borders, it doesn't take anything but a plane ride to bring one of these diseases to a vulnerable community. When I was working in state public health, we had someone return from a trip abroad who had not been vaccinated, and he brought measles back to the United States. And over a period of about 4 days, that individual exposed 400 people from 15 states and 3 countries. Fortunately, because MMR rates were so high, we only had 4 cases that resulted from those exposures, and they were all family members of that individual. But without vaccination, we would have expected 90 times as many cases, and that's just from those exposures. And then there would have been a ripple effect across our state, across other states, as those individuals then went on to infect others. It's important to realize that if I was standing here with measles without symptoms right now, as you do for several days before you get a rash, and the people in this room were not vaccinated, 90% of you would become ill with measles. 90%. What you see on this slide is from a measles simulator from the University of Pittsburgh, and on the left is the impact of 1 case of measles dropped into the District of Columbia with an 80% MMR vaccination rate. And on the other side of the slide is when the vaccination rate is 95%. So that's not 0% and 95%, that's 80% and 95%. While COVID-19 is bad, measles has the ability to spread about three and a half times more, as it's 3.5 times more infectious and about 100 times more likely to kill an unvaccinated child. So, when it comes to messaging, what do? We have a country that has politicized vaccines and public health measures that keep people safer. We have parents who are trying to sift through this huge amount of information and make the best decisions that they can for their children. And sometimes, unfortunately, choosing to roll the dice with with diseases that we can prevent because they somehow think that that's safer than vaccinating against those diseases. We've had declining immunization rates across the country that make communities vulnerable to diseases like measles and polio, diseases that we once celebrated as being eliminated from this country. And we have public health and medical providers who are reluctant to promote vaccines because they fear for their jobs, and sometimes they fear for their safety. But it's not all bad news. Just last week, there was encouraging news that the global immunization rates are edging closer to pre-pandemic levels, and we are beginning to see some improvement in the United States, but we have a long way to go. So where do we go from here? For starters, social media companies need to be held responsible for allowing the amplification of anti-vaccine messaging that puts people at risk. Vaccine opposition on social media has grown significantly, with many previously banned accounts having been reinstated. And the line between free speech and what is public endangerment is thin. But people who promote misinformation about vaccines, who spread blatant lies and conspiracy theories in the interest of self-promotion, or who, for whatever reason, wish to stop parents from protecting their children, should be stopped from spreading their lies. Unfortunately, the lies are titillating to listen to, and the real scientists, the ones who aren't in it for the clicks and the book sales, can't refute them in a simple soundbite. It takes time to explain why thimerosal in a multi-dose flu vaccine is not a problem. And it takes time to explain to parents why following the timing of the CDC's recommended immunization schedule is so important to developing the best possible immunity in their children. And it's exhausting, and sometimes it's dangerous. Social media is a great source of information, but when people can't discern science from myth, the results can literally be deadly. The US is predominantly responsible for the rise in vaccine misinformation across the world, and we cannot allow that power to go unchecked. You may be aware of the recent Fifth Circuit Court injunction that complicates these efforts, but I am confident that we can respect the First Amendment and also meet the constitutional obligation of government to keep people safe. Second, we must provide clear and concise messaging that vaccines are one of the most important advances in modern medicine. They have improved our quality of life by reducing the impact of many infectious diseases and preventing deaths. And there is no legitimate debate here. There are not two sides to this argument. You will not find a single children's hospital or academic medical center in this country that advises against vaccinating children. Why? Because scientists and physicians in those institutions understand the science. They do the actual research. And more than anything, they want to prevent death and suffering. And yes, you can find an individual or even a gaggle of individuals who, for various reasons, help promote the spread of misinformation, and they can be really loud. But for every one of those individuals, there are thousands, if not tens of thousands, of researchers and scientists and physicians who have looked and continue to look at the entirety of the data and who have all drawn the same conclusion, that vaccines protect us individually and they protect us communally. We do not want to return to the days of measles or Haemophilus influenza meningitis or polio, or even chickenpox. The current trajectory that we're on is akin to every disaster movie where the scientists are telling the people that disaster is coming and the planet is in peril, and the masses choose to ignore them. We can work together to turn the ship around and to build confidence in public health and in vaccines. And lastly, as we come out of a pandemic that has changed so much in our lives, we need to be looking to future threats. The massive amounts of emergency funds that were provided to public health in general and to immunization programs in particular allowed for innovation in immunization information systems, increased access to vaccines, and improved public health infrastructure. But unfortunately, much of that funding is being rescinded or will expire in June of next year. Public health has seen this boom and bust of funding with emergencies in the past, and just when we start to think that we're getting ahead of the next crisis, the funding dries up. The Vaccines for Children program that Congress so wisely funded in 1993 in response to a measles epidemic has been a tremendous success, providing more than half of the vaccines for children in the United States and reducing racial and socioeconomic disparities in vaccine uptake. And as Dr. Peacock mentioned, the CDC estimates that among children born between 1994 and 2021, routine childhood vaccinations prevented 472 million illnesses, 30 million hospitalizations, and helped avoid over 1 million deaths, saving nearly $2.2 trillion in societal costs. In addition to VFC, the Section 317 immunization program plays a critical role in supporting the infrastructure of immunizations across the life course in every state and jurisdiction. And while that word infrastructure doesn't always resonate with policymakers, in the simplest terms, this program supports the people and the data systems and the community connections that are necessary for an effective immunization system. The 317 program is critical, but when it comes to vaccine purchase, the available funds have never met the projected need. VFC provides vaccine purchasing funds for children, but only through age 18. Imagine the suffering we could prevent if we had a program like that for adults. We can prevent cancer with hepatitis B and HPV vaccines. We can prevent a large percentage of the 30 to 40,000 Americans who die every day from flu if we can just get them vaccinated. We can prevent suffering from shingles and deaths from pneumococcal pneumonia, but we need a funded program to provide these services to adults who need them. Changes in Medicaid and Medicare to cover vaccines in adults are fantastic, but they leave behind young, medically indigent individuals who earn too much to qualify for Medicaid. And those individuals are disproportionately Black and brown people who must choose between paying for things they need right now and paying for a vaccine that may protect them down the road. The Vaccine for Children program is a 30-year-old model of how to protect people with vaccines they need, but it only covers the first 18 years. And it's time to provide for the rest. I truly believe that this time of politicization of medical science will pass, but I recognize that the sooner it does, the more needless suffering we prevent, the more lives we save. I am so appreciative of this bipartisan effort to have this discussion today, and I look forward to seeing your leadership as we choose the right path forward. And I thank you for your time, and I look forward to your questions. Thank you.
Okay. Well, hold on now. Don't all leave. Saving the best for last. Good morning, everybody. Good morning. Yeah, can you wave your hands so you know you're awake and everything? You got your Wheaties and your coffee? Fantastic. Hi, I'm Ajwa Chimating from the National Minority Equality Forum. And I just want to thank Erin and the March of Dimes for including us in this conversation today, this esteemed panel. Of academics, and we, if you haven't heard of NMQF before, we're the largest nonprofit focused on minority health and health equity. And we're really here to sound the alarm. Very soon, we'll be rolling out our vaccine index, our updated vaccine index of Medicare and Medicaid data across the country showing disparities that exist in vaccine uptake. But we're also on the ground. You know, we were just in New Orleans at Essence Fest. Essence Fest is a fun time. But we were also talking about the flu vaccine. We're also talking about the COVID vaccine, and we were helping with screening. We're going to be in Flint, Michigan, in 3 weeks. Always fun time in Flint, doing the same thing. And then we're going to be in Houston in November. So we're crisscrossing the country, really trying to promote vaccines and immunization. And I have to say, it's pretty difficult nowadays. It's getting difficult by the day. If you aren't on Twitter anymore, I understand it. But right now, what's trending just in the last 24 hours is the story of Bronny James and his cardiac arrest. And it's not trending just because of his incident, but because anti-vaxxers, once again, are using this as an opportunity to spread misinformation about vaccines and tying it, the incident, to the possibility of maybe he received the COVID vaccine. This is what we're facing today. This is what we're facing today, and I really appreciate Dr. Michelle making that point. But I also encourage you, if you will, just to type in this username that's trending also, but not so virally. A gentleman is called @thetronics System. Just looked it up this morning, actually saw it. And he's sharing his story, the Tronics System, about how he didn't get to have the COVID vaccine before he got COVID, and the effect that it's had on his life, that he was facing $700 in medical bills within a month, that he faced swelling in his legs and scarring, that he's on medication to this day, daily, because of long COVID. And so I know that COVID isn't a sexy topic anymore, but we are still concerned about it because of the story of this gentleman that is trending right now on Twitter. So I'm here to talk about the fact that the barriers that we're seeing on the ground, misinformation is a big one. Coverage is a huge one that's exacerbating the disparities we're seeing in vaccine uptake. NMQF, we're really concerned still about COVID vaccination in the sense of that only half of Black and brown people are getting the booster shot. We're concerned that only half of adults have flu coverage. We're concerned that we're seeing the results of the lack of flu coverage, and I'm just going to spit these statistics to you. While 54% of white adults get the flu vaccine, only 42% of Black do, 38% of Hispanic do, and 41% of Native Americans. And then we're really concerned about RSV, which I'll get into in a second. Here on the screen here, you see some solutions that we're suggesting that we're really focused on. We really believe that workplace vaccination clinics make a significant impact on improving vaccination uptake. When you're removing the barrier of transportation, when you're removing the barrier of asking people to take time off of work, which particularly impacts minoritized populations, and you're bringing it right into their workplace, it makes a world of a difference. We really have engaged with health systems across the country, and we see that when there is commitment and also resources provided to health systems and hospitals to do vaccine promotion in disadvantaged communities, we see a difference, because then you allow for leadership to make commitment at the highest level and make their clinicians available to go out and promote vaccines. we see that we need to remove state-level barriers for maternal immunization. And just yesterday, we released a report on our RSV equity action. So if you go to www.rsvequityaction.org, please download that report, because we're very much interested, as the panelists have talked about the importance of the Vaccines for Children program, in seeing the monoclonal antibody immunization for RSV that will allow for it to be one dose for all infants to be protected, to be included in the Vaccines for Children program. And I'll talk a little bit more about that. So here's just a little bit about what we've been doing, just for your awareness. But yes, we are doing education in community. We utilize churches through our Faith Health Alliance. We utilize barbers and stylists through our Wellness Warriors program, because of the importance of trust that has been discussed already. And we utilize pharmacists as well, community pharmacists, because they are interacting with these communities on a daily basis, and when given the opportunity, they can make a significant impact in vaccine uptake. Unfortunately, I would say that COVID, while exacerbated issues in some ways, also allowed for emergency funding to reach disadvantaged populations. And we're extremely concerned that now that COVID has been deemed over, that there's less funding made available to reach these communities. And when I say reaching these communities, I'm talking about patient navigators and community navigators who will go door to door to reach people. We have seen success in our advocacy despite some of these barriers. We're really pleased to see that the Advisory Committee on Immunization Practices did take our recommendation to recommend the high-dose vaccine for older adults. This is particularly significant for Black and brown older adults who tend to have more underlying conditions, of which the high-dose vaccine is extremely important to address. Here's where our focus is as we're going into the fall, RSV. And here's why. You know, RSV particularly impacts children, of course, impacts adults and older adults, but we're concerned about children and infants just because of the fact that Black and brown communities, Asian and Native American communities tend to experience respiratory diseases at a higher rate, tend to be born in environmental communities that have significant burden. And so with these chronic illness, and they are at greater risk for longer and serious illness when contracting RSV as infants. It's really sad when you think about it, that from the beginning of their lives, they're going to be facing higher medical bills, hospitalizations. You know, actually, I wasn't sure if I was going to make it to this hearing today because I was battling the flu. And yes, I'm glad that I've been vaccinated and I don't have underlying conditions, and so I can battle the flu and say, you know, I can still make a congressional briefing. But others are not so lucky. When they see the flu coming, if they've had RSV before as an infant, more than likely they're going to experience a harder time. So here you see the stats. Premature babies are more likely to die from RSV. Unfortunately, African American women tend to give birth to premature babies at a higher rate, 50% higher. RSV incidence is higher, severe RSV incidence is higher amongst Black and brown children. And unfortunately, Native American children are 2 times more likely to experience hospitalization from RSV. And here we come back to the coverage issue and why the Vaccines for Children program is so important. So, treatment costs for RSV when you are hospitalized are significant. If you download our report today, you see I keep mentioning that report, I expect to see a peak of downloads after this briefing. You will see stories in there from real people who have struggled with RSV in their children, facing significant medical bills. RSV hospitalizations then, are unsurprisingly, are almost double amongst children in the lowest income status group. And that infants born in families that rely on Medicaid coverage represent 62% of RSV hospitalizations and 56% of emergency department visits. Just think about the cost to the system, you guys. It's ridiculous, and it's highly preventable. You know, there's been a lot of conversation about vaccine confidence and whether or not parents will allow their children to receive vaccinations. But we see that financial burden is still the major barrier, even when there is awareness of immunization that's available. And so 2/3 of parents in the United States say that RSV presented a financial burden and financial crisis to their families. As we know, Medicaid coverage is extremely inconsistent state to state and cannot be counted on when we're talking about filling in the gaps to prevent continuous inequities in RSV care and just generally immunization, right? So this shows about how much that gap has contributed to the gap, the coverage gap has contributed to these disparities, and that basically no coverage is provided, right? And so as we're looking at our call to action, yes, there should be increased communication, community-led programming in hard-to-reach communities and at-risk communities on immunization, particularly with RSV, as we are preparing for potentially another significant season like last year, where I think you all saw the reports, right, of peaks in RSV incidents. We also are wanting to see more resources provided to healthcare settings, hospitals, health systems, to allow for leadership to commit to their clinicians to fight RSV and to assist low-income mothers in order to encourage them to get immunization for their infants. We would like to see more public health campaigns, and really we value the work we're doing with CDC and MQF. In fact, in the next couple of weeks, we will be putting out a report on the on adult influenza that's coming out in September. We have the RSV report out right now. We will have the vaccine index rolled out in September as well. And yes, I believe that covers it. Oh, and a COVID research report coming out as well. So public health information is important to fight against what we're seeing on social media, but also it's important to encourage people that this is a priority in their community. And most importantly, next week, we really would like to see at the ACIP meeting approval of the new monoclonal antibody RSV immunization to be included in the Vaccines for Children program. I think it's already been shared before the difference the Vaccines for Children program makes in vaccine uptake, and this is especially for Black and brown families. And so for us, we will be really looking forward to saying thank you that the immunization is included in the Vaccines for Children program. So that concludes my chat with you all this morning, but I hope we can continue the conversation. Please visit our website, nmqf.org, because of all the reports that we're rolling out. Also, what communities we're going to. Perhaps we can collaborate with your offices. Actually, we do like to do that. And please download our health equity report on RSV at rsvequityaction.org. Thank you.
All right. Let's start the Q&A. Does anyone have questions for our panelists? First, thank you to all our panelists. You guys did a great job. Thank you. Does anybody have any questions? Any burning things, or do we cover everything? We think we got it all? I do have a question. Of course I do, right? So we've talked about RSV a lot, and you ended on a great note about having ACIP actually include it. If any of the docs could talk a little bit about what is the difference with RSV And what is the opportunity with this new opportunity to get it both in the vaccine for children program, but also what does the vaccine do? Like, what's the difference between this one? Why is it a game changer?
I can start. RSV as a virus causes respiratory disease in young infants. So it really attacks premature babies primarily who have weakened immune systems, plus many of them, their lungs haven't fully developed once they're born and can be easily injured. So respiratory viruses like RSV really tend to go to those kinds of small babies. Very high hospitalization rates. It spreads through the house very quickly. It's brought home by the older children from school. They get a cold, but the babies end up in the hospital. So it really is a big deal. We have had a monoclonal antibody. That's an antibody. It's a protein that we give to premature infants, but they've needed injections into their thigh every month throughout RSV season. It's painful, it's very expensive. Parents have to keep taking their children back to the doctors. So again, this is not a typical vaccine the way you and I would think about it. This is a monoclonal antibody, except it'll last through the entire season. So we literally hospitalize tens of thousands of babies every winter across the United States, and you can give us more of the figures. This is going to be a game changer. This was over 80% effective at keeping children out of the hospital. So not only will it be the highest risk children that have congenital heart disease or who have immune problems or have other conditions, but it will also be good for normal, healthy babies, because the great majority, even though babies who have health problems are at highest risk for being readmitted, it's mostly normal, healthy children who are at home who end up being the bulk of the hospital admissions. So I think this is going to make a really huge difference for us. And if we can cut 80% of the hospitalizations, you're going to save millions and millions of dollars. I don't know if you have anything else.
That was said very well. I mean, I think we pediatricians can think of these examples through the years about how, when the introduction of a vaccine, or in this case a monoclonal antibody that's universally related, can just change that, who's being admitted. I mean, that's what I remember from my training as a pediatrician, is how many children we admitted for RSV, and that's still happening, and this could make all the difference. And I mean, that reduction in 80% is just amazing.
I'll just speak to the difference. So this monoclonal antibody is not technically a vaccine. So when you get a vaccine, that is something that tells your body to produce antibodies to fight a germ if it sees it again down the road. With this product, it is the antibody to fight the germ. So they get an injection of that, and immediately they have the ability to fight that RSV virus if they get infected with it. So the idea here is that they would get the injection in the hospital when they're born during RSV season and go home protected before those other siblings and church and everything else can get them infected. And then for babies who were born earlier in the season that are coming into their first RSV season, they would get that one injection at the beginning of the season at their pediatrician or their family medicine doctor's office to protect them.
Thank you. Any other questions? Oh, good. We got a mic coming too. Hold on.
Thank you for coming. There were several data points about declining vaccine coverage in children and adolescents. But Dr. Davis, you also said that 4 million more children have been vaccinated this year than last year. Could you explain the discrepancy and why it's increasing?
Yeah, I think you saw the data quite nicely, Dr. Peacock. There were so many children so far behind because you couldn't go to the pediatrician's office. They were only taking care of sick kids. They weren't doing well-child visits. So I think now, because of some school requirements, and now that people can go back to the doctors again for well checks, they're being told, okay, you're way behind. let's work on developing a system or a schedule to get your child back to full immunization status. So there's many more children who have gotten vaccinated this year compared to last year, but we're still not close to where we were for pre-pandemic levels. And even those weren't adequate. And what's happened is the pandemic fueled this whole issue related to vaccination, and so there's more and more people that even now are more hesitant about giving their kids immunizations.
And I'll just add that we're getting closer to pre-pandemic vaccination levels, but we missed so many kids that we have to get well above pre-pandemic levels to get all of those kids caught up. And just one comment about the kindergarten data. So every year there is a kindergarten immunization survey that goes out. And depending on which state you're in, that might be a sample of kindergartners, or it might be a complete census where they get immunization records on every kindergartner that's enrolled in public school. If you'll remember from the pandemic, about 10 to 15% of kids moved from public school to homeschooling or to private school during the pandemic, and those numbers have not come up. So while we saw a decline 2 years running of about 1% in the caught up, on-time immunization rates for kindergartners, but we can't get data on the kids that are no longer going to school. So the immunization data on the kindergartners who are in school has dropped for the last 2 years, but there's also this pool of kids, maybe 10 or 15% of kids that used to be in public school that we no longer have data on, and we don't know what their immunization status is, and there's really no way to get it.
But I would encourage all of you to look at your state health department data. I think you'll be shocked. I mean, we had the worst immunization rates in Martha's Vineyard. That's where all the presidents vacation. It was the highest in Massachusetts. There were schools that it was less than 70% for polio coverage in Massachusetts, with wide ranges depending on the community and incredible inequities among different communities. So that's why it's really important for you to look at your states so your senator or representative can say, this is why I think it's important to support our program. Look, even in our state, there's some schools that are reporting inadequate vaccination rates.
Any other questions? Otherwise, I got one more question. Being from the March of Dimes, we work closely with families, and so this is a question for all of you, but really directed to Ajwa. You had talked a lot about trust. You talked a lot about working in the community, and that's something that we during the polio days, that's the reason things happened, right, is because we worked as a community. What would you suggest for all the panelists, but also all of us here in the audience that are working with their members? What can we do to partner with you to help build that trust in our communities?
It's extremely important for policymakers to take a leadership role in communicating the truth about vaccines in their communities. And even, doing a demonstration of going to get their shots themselves and taking that photo and showing that they are walking the walk. In fact, that was just brought up on a call that we has had in Flint, where he said, well, our own mayor hasn't gone for his shot, so how can we convince others to do so? So people watch these things and they take notice of these things. But most importantly, I think it's been said before here that there is still tremendous trust among nurses and doctors in the community, even as there is distrust in the health system overall amongst minoritized populations. And so really making sure that your health systems in your districts have the resources to do real community patient navigation. I cannot tell you how many we talk to that say they just don't have the resources to commit to that. That's a significant problem. And really ensuring that we are equipping and providing funding. We have seen, through our work with CDC actually, what the difference it makes when we are able to make barbers and stylists community health navigators. They're willing to do the work, and clergy as well. And so those are folks that have the trust of folks who are receiving a tremendous amount of misinformation on a daily basis. So really encourage, whenever you see the opportunity to fund programs like that, to take that advantage, because you will see the difference in the data. We see the difference in the data whenever that happens. And then I cannot stress enough that when it comes to misinformation and trust, last year we launched a campaign nationally that looked at who were the most hesitant amongst Black and brown communities, and what were their driving and motivating factors. At the end of the day, their motivating factors was safety for their community, faith, tradition, and so we use that to develop messaging to remind people that faith means that you have faith in the science of the vaccine development, that community safety means that you protect not just yourselves, but your loved ones and your community members by encouraging vaccine within your communities. Be an advocate, essentially. And that we've always had a tradition in this country of, fighting polio, fighting measles, fighting shingles, and overcoming these outbreaks because of vaccines. And so why should we abandon that tradition, that American tradition now? And that's the message that we put out there. Thanks.
Thank you. All right. Well, thank you very much. Oh, we have a question. Go ahead, Abby.
Not on the website, but connect with me afterwards. I'll send you.
All right. Well, thank you very much for all of you coming and sticking it out and listening to the UFO line out here. So I appreciate everybody staying. And if you have any questions, please reach out to any of our panelists. We'll make sure that the slides are available as well as their contact information. So thank you all of you for coming.